So when these virus variants are detected, there's a lot of surveillance that is increased, which is really good because we need to know where the virus is. We need to understand which viruses are affecting different people. And a lot of this is supported through sequencing. Data from the UK, when the Alpha variant emerged and when the Delta variant emerged, there is increased rates of infection across all age groups. There was some suggestion that the variants were specifically targeting children, but that actually is not the case. What we are seeing is that the variants will target those who are socially mixing, those who are out. And if we increase our social mixing and we have people who are unvaccinated, the virus, if the virus is circulating, including the Delta variant, will infect individuals. So let me be very clear. We are not seeing the Delta variant specifically target children. What we do see is that the variants that are circulating will infect people if they are not taking the proper precautions, if there is increased social mixing, if we're not using public health and social measures, if they're not vaccinated. And so this is why we continue to advise this comprehensive package of interventions, whether these are at an individual level, the physical distancing, which remains critically important. Avoiding gatherings, spending more time outdoors than indoors, improving ventilation if you are spending time indoors, getting vaccinated when you can. And so there are a lot of measures there are tools that we have at hand that can keep us, our loved ones, and children safe. With regards to schools, we have recommended a plan for schools to reopen and stay open safely in terms of opening in settings where the virus is controlled, making sure that transmission in the community is driven down to a low level, because you have to remember that schools don't operate in isolation. They operate in communities. And so first and foremost, we need to drive transmission down, and then work with the school systems to make sure that there are certain plans in place, to be able to detect cases, to be able to care for cases, to be able to carry out contact tracing, to be able to communicate with children and their families about the plan, should the virus be detected amongst students or amongst the people who are working at those schools. To make sure that there's good disinfection. If children are age appropriate, to make sure that they can wear masks and that they're supervised in wearing of those masks, etc. So there are ways in which many countries have opened up their schools safely and kept those schools open, because schooling is critically important for children, not only for their education, first and foremost, but also for security, for safety, for their social well-being. And in many situations, this is where children receive their food. So it is really important that schools open, that they open safely. And there are ways in which the schools that can open and can remain open, but we really do need to drive transmission down in the communities to make sure that they can open safely.
I wanted to go back to what Dr. Van Kerkhove was saying about the Delta variant being transmissible. As you've seen, or probably seen in today's reporting with the CDC in the US, there are internal documents that show just how transmissible it is. And for the past several weeks and months, I know that not just the World Health Organization, but other agencies have been struggling with the public health messaging about the Delta variant. So I wanted to know, the recent document shows how it's transmissible as the chicken pox. If Dr. Van Kerkhove or Dr. Ryan or anyone else wants to weigh in, if we could get maybe like 5 bullet points on how you could easily describe, almost at a kindergarten level or a very simple level, the concerns about the Delta variant.
So perhaps I could start, and maybe Mike would like to come in. I mean, I think your question kind of highlights the challenges of being able to communicate about this. The virus itself, as it starts, is a dangerous virus. It's a highly transmissible virus. The Delta variant is even more so. It's doubly more transmissible than the ancestral strains. And it's about 50% more transmissible than the Alpha strain. From a public point of view, if I was describing this at a kindergarten level to my own kids, it's a highly transmissible virus, whether it's 100% or 1,000% or whatever percent more transmissible. This virus will spread if we allow it to. And so the bottom line is that we need to do everything we can to protect us, to protect ourselves, and to protect our loved ones. And we can do that. So what we need to do is continue to keep ourselves safe by physical distancing, by wearing a mask, by keeping our hands clean, by spending more time outdoors than indoors. We need policies that are in place that enable people to work safely, go to school safely, live their lives safely. And a lot of this is around making sure that these policies allow to adhere to these individual level measures to improve ventilation in indoor spaces, to make sure that we have vaccines and we have access to vaccines, and that the vaccination plans that countries all over the world that have worked so hard to develop are able to be implemented by having access to that vaccines. We need to work against vaccine hesitancy and vaccine acceptance, making sure that people receive those vaccines. So from the Delta variant, the Delta variant is dangerous. The Delta variant can transmit. It is more transmissible, the most transmissible virus, SARS-CoV-2 virus to date. But this will not be the last virus variant that you hear us talking about. And so what we need to do is move away from the next latest virus, right? The next latest variant, because there will be more. And it's in the virus's interest. Viruses are not alive, so they don't have a brain to think through this, but they become more fit the more that they circulate. And so the virus will likely become more transmissible because this is what viruses do. They evolve, they change over time. And so we have to do what we can to drive it down. So again, it wasn't your 5 bulleted short point answers, but it's more transmissible, and it's the most transmissible virus to date, but we have the tools at hand that can reduce the spread. So I think that's what we really need to be focused on.
Yeah, I wouldn't characterize us as struggling to communicate on variants, and specifically on the Delta. We've been speaking about this for months now and tracking this virus through our virus evolution working group and through the wonderful work going on all over the world by so many labs in tracking this virus within the public health systems. And the dangers posed by Delta have been raised time and time again by the Director General and by WHO. Fully understanding the dynamics of how and why it is more transmissible is still taking time to determine, and there's a lot of studies underway to try and understand that, because that may affect what we do about this virus. But if we're explaining this to ourselves, and it's not just at kindergarten level, in some senses we're all in kindergarten when it comes to this virus. We're still learning, and we've taken baby steps in trying to control this virus, but we're going to and we're explaining this to people. Essentially it comes down to on average one person with this virus will infect more new people if they have the Delta strain, unless we prevent that by continuing to practice the measures that reduce transmission, like physical distance and wearing masks and hand hygiene, and ensuring that we're not spending time in poorly ventilated spaces with lots of other people, and all of the other measures that we've spoken about again and again. The same measures that we've applied before will stop this virus. They are stopping Delta strain, especially when you add in vaccination. But we need to work harder. The virus has got fitter. The virus has got faster. It doesn't change our game plan. The game plan still works, but we need to implement and execute our game plan much more efficiently and much more effectively than we've ever done before. And that includes getting more vaccines out there, increasing and improving. DG spoke about it. He said it in a speech. He laid it out. These are the things we need to do more of, and we need to do much better, and we need to do much faster. There are no golden silver bullets here. There are no magical solutions. There's no magic dust. It's been the way for the last 18 months, and people keep asking for magic dust. It doesn't exist. The one magic dust we do have is vaccination. Problem is, we're not sprinting that evenly around the world, and we're working against ourselves. So from that perspective, Delta is a warning. It's a warning that this virus is evolving, but it's also a call to action that we need to move now before more dangerous variants emerge.
Just come back, Angeli, to your question. When people say a virus is more transmissible in this case and what it means, as Mike Maria said, it's simple. More transmissible means more cases, more sick people, more hospitalizations, more ICUs filling up, which brings us to a choice. Do we do more stuff to stop it at an individual level, like Mike and Maria laid out, or do we have to go to more lockdowns to stop it? It's that simple. More cases, more sick people, more hospitalizations, more ICU overload, and then you get to your choice point. More lockdowns or more stuff to stop it by using your masks, using your distancing and your other measures. But then to the other point, just take a step back from one of the earlier questions, about vaccines and their equitable use. We could be at a very different point right now. Since the Director General held his last press conference, we have moved past 4 billion doses of vaccine administered. Now, if those vaccines had been administered to people over 60 years of age and at risk around the world, we basically could have gotten 2 doses into everybody at highest risk of severe consequences when we got to a disease or a strain like the Delta strain. We actually could have vaccinated them twice. That's how much vaccine's been used in the world. But because we haven't, we are seeing in so many countries now what we're calling, a diverging epidemiology. In one set of countries, we're seeing the cases go up, but the deaths stay low. In other countries, we're seeing the cases and the deaths go up. And that's another choice that we've got to make as a global community. Are we going to change that now and change it such that in both settings, cases may go up, variants may become more transmissible, but deaths and hospitalizations stay low. And that's that choice we make about the fair and equitable distribution of vaccines around the world. We've seen great improvements, and a huge shout out to those countries that have been sharing doses, to those manufacturers that have started to prioritize the low-income countries, but we are only at 1/10 of the level of the high-income countries still when it comes to the number of doses per 100 population. And in the face of the Delta variant, they're going to pay a very, very different price as a result.
Sure, Tarek. So perhaps I could start, but I think there's 2 parts to this question. One part to this question relates to exactly how it was asked in terms of risk groups. But I think the second part of this question has to do with priority groups for vaccination. In terms of groups that are at risk for developing severe disease, groups that are at risk for death from infection from the SARS-CoV-2 virus, those have remained relatively stable over time. We know people of advanced age, people over the age of 60, and as age increases, the risk of developing severe disease and dying increases as age increases. We know with people with underlying conditions, such as chronic respiratory conditions, cardiovascular disease, HIV, obesity, diabetes, have an increased risk for developing severe disease and dying. What we do know is that over time, we do see a shift in terms of the age range in which people are getting infected. And again, that has to do with how social mixing patterns happen. If you remember, even a year ago, more than a year ago now, last spring in the Northern Hemisphere, we saw what appeared to be an age shift in the average age of infection. And people were wondering, has the epidemiology changed? Has the virus changed? But in fact, what that was due to was the fact that older individuals were staying home more, younger individuals who had to leave their home to go work were leaving their home and were increasing the number of contacts that they had and were at a higher risk of exposure and therefore at a higher risk of infection. But in terms of those people who are at an increased risk for developing severe disease and dying, it's those that have underlying medical conditions of any age. This includes children and people who are over the age of 60. And we know that, again, the increased risk increases substantially as age increases. And then, so there are differences as we see in terms of the infection rates. But again, over time, as individuals who are of the older age groups, those who have underlying conditions, those groups are prioritized for vaccination first. Those individuals are protected against severe disease and death because, again, we have several safe and effective vaccines that prevent against severe disease and death. We need access to those vaccines that actually have them work. And this is why we need good vaccine equity around the world. And so that's the shift that we see.
Thank you very much, Dr. Aylward. Would you like to add on a second part?
I think Maria was clear in answering the question. The prioritization of vaccination has got to still follow the order of priorities that Maria talked about in terms of severe disease and death. What we are seeing, though, in the high-income countries, as you alluded to, Peter, we're seeing this divergence now in the epidemiology, right? It's a fancy way of just saying that what the outbreak looks like and the damage it's doing, what it looks like in populations in high-income vaccinating countries is starting to look very different from what we're seeing in the low-income non-vaccinating countries because they don't have access to vaccines. And so if there needs to be a shift in our prioritization, it's not in terms of our target groups, who we're vaccinating. The shift needs to be in where we're vaccinating, that we need to look at vaccinating. Great, we've covered the high risk and highest older populations, health workers, et cetera, in the high-income countries. We need to make sure we are doing it in the low-income and other countries. So before we start moving down age groups, we need to look geographically at what we're doing. And again, as we've seen, you'll remember when we first started talking about Delta virus and the various other strains, these were only found in 1 or 2 countries, but they very rapidly now, as the Director General said in his comments, spread everywhere. 132 countries now that we know have the Delta virus. There's probably many more. So, you know, it's a bit of a fool's bargain to think that you can vaccinate your way out of this in one country without paying attention to the rest of the world. And I think that message is getting through now. We're starting to see more donations in response to the call and more sharing of vaccines and doses in response to the Director General's call, but we're still nowhere near the numbers we need to get to if we're going to get, you know, at least 10% of the population, 20% of the population vaccinated in the majority of the world's countries. So yes, as we see more disease in younger populations as a result of the fact that older populations are vaccinated in many parts of the world, we still need to remember and look at geographically, there are huge parts of the world where those most at risk of dying are not vaccinated. And that's the reason the most alarming statistic and what the Director General said in his comments this morning was the 80% increase in deaths in Africa over the last 4 weeks. This should be completely unacceptable on a global scale. The fact that we can even say those numbers without reacting to them that way, this should be completely unacceptable in an era where we have powerful, effective vaccines, where you have billions of doses of them, and in some parts of the world, 80% increase in deaths. Completely unacceptable. We can't change that unless we shift our priorities from who gets us to where they're getting it and make sure there's equity in the distribution of these products.